Good morning, everyone. Let me first start by thanking Dr. Matthew John, Dr. Tuman, the Providence team, as well as the Abbott Thyroid Division for this wonderful update on thyroid, and also for giving me this opportunity to be a speaker for this symposium. And my topic for today is low TSH in first trimester of pregnancy. I'm Dr. Raj Mohan, endocrinologist with Dr. Mohan's Diabetes Center and King's Hospital, as you can see here. And I would like to present some theory about this topic as well as some cases we discussed. And hopefully it will be a good experience for you all. So before starting, we'll have a quick update on the thyroid physiology. As we all know, a lot of changes in pregnancy. The physiological changes are there, not only in thyroid, but also in most of the other organs in the body. And there is alteration in the thyroid also because of that. And physiological changes are 20% increase in thyroid gland due to hyperplasia and vascularity. T4 production increases approximately 50% starting in early pregnancy. And the rarely thyroid gland enlargement causes goiter unless the patient is thyroid in deficient areas. And plasma iodide levels usually decrease because of the increased utilization by the fetus as well as placental losses and maternal renal losses. Now, apart from that, there is also influence of two other hormones, HCG as well as estrogen. HCG, as you all know, is very high in pregnancy, and this hormone, human chorionic gonadotropin, shares very structural homology with the thyrotropin, otherwise known as the TSH. And because of that, it binds to the thyroid gland TSH receptors and exhibit weak thyrotropic stimulation, the subsequent hormone production, especially in the first trimester. And as you can see in this graph, it goes up initially, and then after that, it comes down, and then it goes down. And because of that, there is a significant relationship between TSH level and HCG. And as you can see there, when TSH level goes up, HCG level goes up, TSH naturally comes down, and after that, it plateaus at some point. And in multiple pregnancies, the normal shift in TSH is much greater. In a study in 63 women in HCG concentration more than 200,000, TSH was suppressed less than 0.2. In 67% of the women, in 100% of the women, the HCG was more than 400, was suppressed more than 100% in all the patients. And estrogen stimulates the liver to produce TBG and thyroid binding globulin, which is a major transport protein for the thyroid hormone, and it extends half-life. And significant increase in secretion of TBG is almost 200%. Because of that, there's a lower free thyroid hormone and stimulates positive feedback to the HPT axis, the hypothalamus pituitary thyroid axis, and there is reduced peripheral TBG degradation rate. And because of all these factors, there is 80% TBG greater affinity and greater binding, and there is increase in total but not free thyroid hormone, which remains usually within the normal range. Now, these are some of the physiological changes that occurs because of increase in TBG. There is increased T4 T3 concentration. Plasma volume is high. There is because of that also there is increased T4 T3 pool size, and there is increase in cardiac output. Because of the HCG, as I just mentioned, there is decrease in the TSH and increase in T4 production, increased renal iodine clearance because of that increased iodine requirement, and increased T4 production, fetal T4 synthesis during second and third trimester. This iodine requirement is high, so that's why they have national program. They have introduced the iodination program of all the salt, which reduce the burden of cretinism a lot in this country, and of course increased oxygen consumption by the fetal-placental unit. And these are some of the effect on the body: iodine clearance, relative iodine deficient state, placental deadenation of T4. T4 is changed to reverse T3. Increased TBG causes increased T4 levels. Increase in HCG, there is a decreased TSH and increased free T4, mostly free T4 and TSH T4 also to some extent. And thyroid receptor antibody is reduced. There might be some Graves' disease improvement in the early stage of pregnancy. And postpartum stage, there is increase in thyroid antibody, which causes Graves' disease exacerbation or postpartum thyroiditis. And this is the TSH levels during pregnancy, which is trimester specific reference range mentioned in with the optimal iodine intake. As you can see in this graph, the TSH levels in the first, second, and third trimester are much lower than the normal adult TSH levels. So it is that is why they want to keep it below this level to make it euthyroid. And this graph depicts the various effects of the various hormones, the interplay between the hormones, and HCG being the highest increase, and because of that corresponding increase in TSH. After that, it goes down, and increase in TBG level. Because of that, total T4 also mirrors that increase. So that is when up to 15 to 20 weeks there is a acute rise in T4 concentration. So they always say to check the T4, free T4 in the first trimester second and third trimester, check the T4 and total T4 levels rather than free T4 levels, because total T4 levels are more predictable. It is 50% upper limit of normal. Upper limit, if you take it as this line, the upper limit will be much 50% higher in the second and third trimester. And the TSH, as I mentioned here, is lower. Free T4 usually is the lower side, and after that it stabilizes. But free T4 is also a bit difficult to detect. I mean, assay is also the reference range should be available. Then only free T4 becomes a very reliable test in pregnancy. So what happens in the fetus? The maternal thyroxine in coelomic fluid starts producing in 6 weeks. T3 is present in fetal brain from 7 weeks onwards. Discharge expression in the brain at 8 weeks, and the fetal iodine uptake starts occurring about 10 to 14 weeks. And fetal thyroxine secretion occurs only around 4th month, that is only 18 weeks. So that is why it's very important that a mother should be euthyroid, at least not hypothyroid. Hypothyroid still it's not very bad, whereas hypothyroid can cause very severe effect on the baby's thyroid levels. So this is the baby's levels which is mentioned. They all start very low levels in the early stage. So that is very important that mother's thyroid should be under control. Now, fetal thyroid begins concentrating by about 10 to 12 weeks and produces thyroid hormone between 15 to 18 weeks. Although fetal thyroid is functional, it still depends on adequate amounts of iodine from the mother. And placental transfer of maternal T4, T3 is believed to occur prior to the fetal thyroid hormone synthesis and continues thereafter. So it might be the only source of thyroid hormone during the early life, and is for brain maturation of the developing child. Now, what about the incidence of hyperthyroidism in pregnancy? That is our topic for this talk. Wang et al. From China, they demonstrated close to 1% in the first trimester. I'm talking about the biochemical. I'm not talking about clinical thyrotoxicosis, but about biochemical hypothyroidism. In Vaidya in UK, they demonstrated about 0.7%, and Lazarus in 9 to 15 weeks, it was about 1.4%, and USA, the patient that took us less than 20 weeks was about 0.4%. Because around 20 weeks, it tends to plateau down. The incidence of abnormal thyroid function tends to come down. So what are the actual causes of thyrotoxicosis? The thyrotoxicosis and hypothyroidism are slightly different. Thyrotoxicosis, there should be a state of toxic state. And intrinsic thyroid disease, it could be Graves' disease, is a very commonest cause. Toxic nodule, or could be seborrheic thyroiditis because of some viral infection or something like that. Exogenous thyroid hormone, the patient is taking thyroxine that is more than the requirement the patient is taking, that can result in therapeutic exogenous high levels of thyroid hormones. And of course, a more common cause is gestational thyrotoxicosis, hyperemesis. I will explain that in a couple of slides later. Gestational thyroid disease, hydatiform mode, multiple gestation, hydrops fetalis, and rarely TSH producing tumor, iodine deficiency, and all. Tumor can cause hyperthyroidism. So what exactly is gestational thyrotoxicosis? It is a transient state, as mentioned here, gestational transient thyrotoxicosis. It is because of the cross reactivity between HCG and TSH at the receptor level. TSH receptor level is the thyroid. And usually thyroid receptor antibodies are absent. They are rarely symptomatic. They might have because a lot of hyperemesis, so nausea, vomiting, dehydration, electrolyte imbalance, and weight loss might be there. So some of the symptoms overlap between frank hyperthyroidism and hyperemesis, gestational thyrotoxicosis. Usually resolves by about 18 weeks, because at that time the HCG levels start to drop and then TSH tends to normalize. Antithyroid medications are usually not required. It is seen in about 10 to 15% of pregnant women during early pregnancy, and mildly increased free T4 and suppressed TSH early in pregnancy, not due to intrinsic thyroid pathology. Characterized by mild or no symptoms and resolved spontaneously by the second half. No evidence of thyroid autoimmunity when evaluating thyroid antibodies or monoglobulin. Associated with hyperemesis, also with hydatiform mode, secondary to high levels of HCG that can lead to TSH receptor stimulation. Rarely symptomatic, no treatment with antithyroid medication is required. So management depends on the severity of symptoms. Hyperemesis should be treated with fluids and prevent dehydration and antiemetics. Antithyroid usually not warranted unless they are very high in patients, very toxic. Studies show the obstetric outcome is also not improved in women treated with antithyroid drugs for gestational hyperthyroidism. So we have the case based on this situation. 30-year-old female, 12th week of pregnancy, second pregnancy, vomiting about 15 times daily, epigastric pain since the 10th week of gestation. She has nausea, giddiness, tiredness, loss of appetite, lethargy, loss of weight, etc. No symptoms suggestive hyperthyroidism. For example, she does not have tremor, does not have tachycardia, etc. And the first pregnancy was fairly okay. There's no other family history of thyroid disease, no other medical history of the patient. And patient was febrile, alert and conscious, but she was obviously dehydrated because of the vomiting. And she was mildly tachycardic. Her pulse rate was 108, BP was 100 by 60. No hand tremors or interest was present. Now, bilirubin marginally elevated, serum potassium is a bit low because of the potassium is low because possibly because of vomiting. Free T4, as you can see, that free T4, the level is 35, her level is about 45. So it's only marginally high. TSH is low. So we cannot take it as high, very severe hypothyroidism and start treating this case. We have to look at the clinical situation. So TSH receptor antibody can be done, but usually not required in every cases. If you are suspect if it's equivocal, for example, the free T4 was about 2 point something, maybe we may have a doubt that she may have underlying Graves' disease, then we can send off for TSH receptor antibody also, which is not freely available in all the clinics, and the test also will take a few 10 days to come back and all. So she was treated with IV saline, potassium chloride, antithyroid was not given, and TFT 10 started to normalize by about 13 weeks, and vomiting also significantly reduced. And so this is a case of hyperemesis gravidarum with gestational transient hypothyroidism. So this one I mentioned here, when the free HCG levels goes up, TSH goes down, and the patient can have abnormal thyroid function there. So the clinical characteristics of hyperemesis is that absence of hypothyroid symptoms prior to conception, similar history of vomiting in previous pregnancy might be there, might not be there. Family history of hyperemesis might be there, no previous history of thyroid disease. Physical examination, no goiter, no absorptopathy, no lipopathy, no other physical findings of other autoimmune diseases like vitiligo. There might be signs of dehydration. Free T4 usually elevated, and TSH will be low, but antibodies will be negative, and electrolyte abnormalities and minor LFT dysfunction might be present. So this is the management. ATD is not recommended. No benefit according to studies and case reports. Supportive treatment is warranted, and transient free T4 levels normalize by itself without any treatment. And ATD should be started if the patient persistent hypothyroid symptoms and abnormal LFT after 18 to 20 weeks. Because it might indicate that it might be underlying Graves also. The Graves disease, they can have superimposed gestational thyrotoxicosis. But usually studies have shown that there's no maternal or fetal outcome because of the gestational hypothyroidism. So guidelines, according to there is a very nice guidelines in the 2017 ATA guidelines. It is freely available in the internet. You can just type in ATA thyroid pregnancy guidelines. It has both thyroid hypothyroidism, thyroid nodule, thyroid cancer, everything is discussed in detail. So whoever is interested, they can go into the internet, and then you can freely download the PDF for that topic. So the recommendation 42, I'm coming to the hypothyroid recommendations. Appropriate management of normal maternal thyroid tests attributable to gestational transient thyrotoxicosis and or hyperemesis include only supportive therapy, management dehydration, hospitalization. Anti-thyroid drugs are not recommended. Beta blockers might be considered, but high dose beta blockers not recommended in pregnancy because of the risk of IUGR can occur, fetal bradycardia can occur. So usually very minimal dose we can give. If at all it is required, the patient is very symptomatic, propranolol can be given. So we have another case, Mrs. Lakshmi, 29-year-old primary, 8-week of gestation. She was referred by gynec, very common referral to our endocrine clinic. The gynec sees the TSH is low, marginally low, 0.1, and free T was normal. They refer for a follow-up. A patient is usually asymptomatic, not even nausea. She does not have hyperemesis also. So this is subclinical hypothyroidism. Free T3, T4, and T3 are normal. TSH is low. No effect on the fetus. No need for anti-thyroid drugs. Beta blockers might be used, but usually we don't require any treatment for such patients. We just need to reassure and also recheck after about 3 to 4 weeks to make sure it doesn't get worse. So we have another case, 28-year-old lady, 11th week of pregnancy, presenting with palpitation, sweating, restlessness, nausea for over 3 weeks. So she has some of the symptoms which might suggest that she has thyrotoxicosis. And also she has a goiter, the bruit, and mild exothermos. So all are classical for a Graves' disease with thyrotoxicosis, tachycardic, and free T4, as you can see, there is about more than 2.5 times upper limit of normal. TSH is very low. And TRAB, thyroid receptor antibody, is sent, which is pending. Previous history of treatment for thyroid disease at the age of 80. So she has a history of thyroid disease. Possibly it could have been Graves, it could have been any other disease, but we don't have much details about that. So this is a common scenario. Graves' disease in pregnancy is about 0.5%. Most common causes of hyperthyroidism, that is, thyroid itself is overproduction from the pregnancy. That is, Graves' disease is a common triad of hypothyroidism, exothermos, and preterm exedema. Might not be always there. Exothermos is also only 30 to 40% in all cases of Graves' disease, so need not be always present. But thyroid goiter may be there, thyroid bruit may be there. Physiologically, thyroid receptor antibody will be very high. So how do you differentiate between gestational hypothyroidism and Graves' disease? Graves' disease is slightly less common compared to gestational hypothyroidism. Hyperemesis might be present, but in gestational hypothyroidism is very severe and usually thyrotoxic symptoms. But in gestational hypothyroidism might have a bit of tachycardia because of the dehydration. And T4 levels are usually 3 to 5 times upper limit of normal, whereas T4 elevation is there, might be there, but it's not very marked. Maybe 1.5 times, maximum 2 times upper limit. Then goiter with bruit and eye signs might be there. Here, no goiter. Thyroid receptor antibody is 95% sensitive for Graves' disease, but it's not. I mean, it's very specific for Graves' disease, but its sensitivity is probably about 75 to 80%. Most of the cases will be positive. So if you have doubtful, if your clinically is not very clear, the eye signs are not there, classical, we can then send off for the thyroid receptor antibody. Minimal fetal effects, almost nil fetal effects. Sorry, whereas maternal fetal effects are there. It's usually self-limiting, whereas this one needs anti-thyroid medication. So in pregnancy, usually Graves' disease, there is exacerbation can occur because of the HCG. So HCG as well as overproduction because of Graves can occur, but usually it improves later on when the pregnancy progresses because of the relative immunosuppression in pregnancy and the levels of receptor antibodies may fall. And pregnancy has no effect on the Graves of thyroidopathy. So what are the effects on the pregnancy? They might have miscarriage, they may have thyroid storm, pregnancy-induced hypertension, heart failure, preterm labor, and placental abruption can occur because of that hypothyroidism. Then what about in the fetus? The patient can have stillbirth. Patient can technically cause hypothyroidism. If the dose of antithyroid drugs are very high, patient can develop hypothyroidism. I mean, the fetus can develop hypothyroidism. Low birth weight and IUG, especially common with the use of beta blockers. The child can develop goiter, especially thyroid receptor antibodies are very high, and sometimes rarely they can present with the fetal hyperthyroidism also. So this is a study of forward thyrotoxicosis in pregnancy. Preeclampsia rate was higher, heart failure also much higher. Death fortunately was not common. Preterm delivery also higher, growth restriction was higher, stillbirth was higher. So most of the times treated and euthyroid they fare better compared to the uncontrolled thyrotoxicosis. So presentation of hypothyroidism is almost similar to most of the other cases of thyrotoxicosis: nervousness, agitation, tachycardia, palpitation, weight loss, increased appetite, skin moist, onycholysis, hair soft, eye signs, etc. And recommendation is that hypothyroidism should be distinguished from other causes of abnormal TSH in pregnancy, like normal physiological variation or hyperemesis. Diagnosis based on the presence of goiter as well as other features of autoimmunity and presence of anti-thyroid receptor antibody. So thienamides are the treatment of choice. Usually PTU is the drug of choice. In case of allergy or intolerance, carbimazole can be substituted. So in pregnancy, current recommendation is PTU 5 to 10 milligram of usually 100 to 200 milligram PTU is given. MMI is methimazole, but here we have more of carbimazole. Pregnant women receiving methimazole who are in need of continuing therapy during pregnancy should be switched to PTU as early as possible, and usually is given up to 16 weeks of pregnancy, after which we can change to carbimazole. Because PTU has a small risk of liver toxicity and liver failure has been reported. Patients have died because of PTU, but not that common, very, very uncommon side effect. But since it is a quite serious side effect, some people recommendation is to change to carbimazole after 4 months. After 16 weeks, it's still clear whether PTU should be changed to MMI, but as a general rule, I changed from PTU to carbimazole because it's potentially less fatal and less serious side effects. Antithyroid drugs inhibit the adenation of thyroglobulin and thyroglobulin synthesis. PTU blocks the T4 to T3 conversion, usually crosses the placenta. Initial dose is 100 to 600. Usually we give 50 BD. I give much. These are all standard doses for the Western population. I give lower doses, 50 to 100 milligram per day, and then go up according to the T4 levels. Methimazole can cause aplasia, cutis, esophageal atresia, etc., etc. And with PTU as well as with carbimazole, there can be hepatitis, rashes, leukopenia, etc. Birth defects also common with MMI, less common with PTU. So according to the FDA, the PTU has 3 times less chances of congenital malformation compared to methimazole. So in the first trimester, definitely PTU is the drug of choice unless PTU is contraindicated because of allergy or something else. Beta blockers can be given for symptomatic relief, and of course, thyroidectomy in severe cases not controlled with medication. Iodine cannot be given, of course. So recommendation is should be monitored. The drug level should be monitored every 4 weeks, and anti-thyroid medication should be adjusted. And your target should be to keep the T4 levels at the upper range of normal. Around 1.5 times upper range of normal is the range, so we can keep it in that pregnancy specific range. So block between. So I think this one I just mentioned. So when serum TSH is low, we should do a free T4 or T4 conservation, and measurement of TRAB and maternal antibody may be helpful in some cases to say the etiology. So we have another case, Mrs. Rama, 28-year-old primary, past history of treatment for Graves' disease. Now euthyroid, TSH as you can see there, early pregnancy is normal, 3 T4 is normal, but her TRAB levels are much higher. Normal is less than 1. So hers is about 3 times the upper limit of normal. So what should we do for these cases? What is TSH receptor antibody or TRAB? TRAB is a general term to define an antibody that binds to TSH receptor. It can stimulate, block, or be neutral to the thyroid receptor, but usually in Graves' disease, it's a stimulating antibody. So the Graves' disease due to antibody that stimulates the thyroid receptor. TRAB is usually confirming the diagnosis of Graves' disease. Pre-conception, the presence of elevated TRAB is prognostic of risk of relapse of growth hormone or failing ATD cessation. During pregnancy, TRAB crosses the placenta. That's the problem with TRAB. It crosses the placenta and can induce fetal hypothyroidism, especially the levels are very high as I just shown in the earlier patient. TRAB levels over 3 times upper limit of normal associated with hypothyroidism in the fetus and newborn. So we should inform the neonatologist about such a complication. So this is a TSH here stimulates the thyroid receptor, whereas the TRAB itself will stimulate the thyroid receptor without the levels of irrespective of levels of TSH. So TRAB should be checked in a pregnant woman with a past history of Graves' disease. If the TRAB levels are low, then no further testing is required. But if it is elevated, patient if is treated with ATD, it should be measured again between 18 to 22 weeks. And if it is more than 3 to 4 times upper limit of normal, it should be checked again during the 28 to 34 weeks. And it can be a risk for a neonatal hypothyroidism, especially more than the 3 times upper limit of normal in the 3rd trimester. So this is a recommendation. Past history of thyroid disease, Graves' disease, we should do TRAB during early pregnancy. If maternal TRAB is elevated early pregnancy, it should be repeated 18 to 22 weeks. And if it's going down, then no need to check again. But if it's going up, we should check again at 28 weeks. And if it is 28 weeks, if it is high, more than 3 times, we should caution. We should tell the radiologist that they should check for fetal goiter as well as for fetal tachycardia. So this TRAB has been TPO antibody has been associated with pregnancy loss, but it has no role for the hyperthyroidism. So TPO should not be done in any case of suspected hyperthyroidism. For hyperthyroidism, TRAB should be done. TPO, a lot of people just do TPO antibody for any case of thyroid. That's not required. TPO is only required if it is a hypothyroidism. It's specific for hypothyroidism, Hashimoto's thyroiditis. So please don't do TPO for all the patients with thyroid problem. TRAB should be done. Thyroid receptor antibody. They should ask for thyroid receptor antibody, which is very expensive. So I think a physician should not order themselves. You should leave it to the endocrinologist to order, because otherwise it will be difficult to interpret. But sometimes if a patient is hyperthyroid, we can check the thyroid receptor antibody to see whether it's a Graves' disease or not. So pre-conception counseling should be done. Hyperthyroidism under treatment. Side effects of anti-thyroid drugs in the fetus should be mentioned. Wait 6 months after radioablation, and the patient should be euthyroid at the time of conception. Previous ablation for Graves' disease, we should check the thyroid receptor antibody, and then we should check accordingly after, as I mentioned earlier. So this is a final side. This is the algorithm for thyroid function. If TSH is low, then we should check the free T4. If free T4 is normal, possibly subclinical hypothyroidism, then usually not anything is required, but make sure you repeat after 4 to 6 weeks. If it is a high free T4, then we should overt hypothyroidism. We should check for presence of goiter, Graves' orthopathy. There's no goiter or TRAB is negative, then it could be gestational thyrotoxicosis. We should repeat the thyroid function test. But if it's goiter is there or ophthalmopathy is there, then treat as for Graves' disease. PTU in the 1st trimester, switch to carbimazole in the 2nd trimester, and monitor thyroid function test every 4 to 6 weeks to keep the free T4 in the upper normal range. Thank you. So any questions, please? Thank you very much.